lecture, so those who are late or skip the lecture, they can look in the recording. So today's topic is adrenergic antagonists, and adrenergic antagonists or adrenal blockers or sympatholytics. These are all the synonyms. They block the adrenergic receptors and prevent the action of the sympathetic nervous system. That is why they're called sympatholytics sometimes. And these drugs are most important in clinics because they have so many indications, and very common diseases are treated with beta blockers, and alpha blockers are used in emergency medicine, and usually the indications are connected with the cardiovascular system. So most drugs in this group will be used to treat the cardiovascular system. The adrenal blockers are divided the same way as the adrenoreceptor agonists. They are divided by the type of the receptor they block, and the classification includes the alpha alpha blockers that are represented by the phenoxybenzamide, that is a non-competitive block, and also others are competitive, phentolamine, and phenoxybenzamide and phentolamine are non-selective alpha blockers. They will block both types of the alpha receptors, alpha 1, alpha 2, and the prazosin, tamsulosin, and teirazine are selective alpha 1 blockers and will only block the alpha 1 subtype of receptors. And then there are also alfuzosin, and the new one, tamsulosin, is selective alpha 1 A receptor blocker, subtype receptor blocker, and Johann. So these are the alpha blockers. Then the beta blockers is the largest group and include non-selective propranolol. Propranolol is a non-selective beta blocker, will block all subtypes of the beta receptors, and it's most research drug available nowadays, and still is clinically important and used in clinics. And then the selective beta blockers include the metoprolol. Metoprolol is the also most researched and important drug in the world now, and metoprolol is selective beta 1 blocker, or cardioselective, because beta 1 receptors are in the heart. And then the atenolol has common features with the metoprolol, because atenolol is also beta 1 blocker, but for some reason it is not as effective as the metoprolol. So they have common properties, but clinical effectiveness is less with atenolol, and that is why recent times the physicians stopped prescribing atenolol and only prescribe metoprolol. And then we have many, and notice that all the beta blockers, they have all at the end. So this is very convenient. So because if you see all at the end, then you can easily find out that this is a beta blocker, and vice versa. So then we have other beta blockers that are actually very different from each other, and some of them are partial blockers, some of them are uh, antagonists. So some of them have also agonistic activity, so we will return to them later. And also the labetalol has an alpha 1 blocking property, so it is a beta blocker, but the ending is LO. That is why, because of the R is alpha blocking, that is why LO, no OO, like all other beta blockers. And then there is an indirect blocker is reserpine. Reserpine is obtained from the plant, so it's a herb, medicinal herb. Obtained from the medicinal herb. And reserpine is a non-direct blocker that acts on reuptake and release of the epinephrine. So these are the classification of beta blockers. And we will start with the alpha blockers, because alpha blockers have less applications and easier to learn. So, and also they have alpha because it is the first letter of the alphabet, so alpha are more important in the, so alpha usually the first one, so that is why we start, but they are not first line medicines. So from all of these, the tamsulosin is most used, and the application, so the indication for the tamsulosin is very, so it's like not very common, so not very important actually, only for the men. So are there any males today? So it's an Ibrahim Ali. So these are for us, so it's good that you are here. And so actually this, so tamsulosin is actually for the old men that and used to treat the erectile dysfunctions, so the only application for that. Others like prazazine, terazazine, and doxazazine are used to treat the hypertensive emergencies, and are rarely used to treat hypertension itself because of the reflective tachycardia. So okay, let's look at the action of the alpha and beta blockers, and the action of the alpha-adreno mimetics. And I'm sorry, I have a little running nose today. So the so I think I need some α-adreno mimetic from the previous lecture to treat the running nose today, to be able to continue lecture for the adrenomimetics. So uh, the pretreatment actually, so this is a control that is untreated, means that there is no any drug added before. So, and then pretreatment means that we add the blocker, alpha blocker or beta blocker before we administer the drug. So, and as you can see, when we administer alpha blocker before the application of the or prescribing the isoproterenol. Isoproterenol is a pure beta adrenomimetic, and then this is the change in the uh, arterial pressure. So, and the pressure is the same as before. So it will decrease because of the action of the isoproterenol, because isoproterenol will relax the beta adrenoreceptors in the vessels that uh, uh, that give blood to the skeletal muscles, and also isoproterenol. Uh, so this is the action on the arterial pressure or blood pressure. But if we pre-treat with the beta blocker, then this action will be blocked by the beta blockers. So, and then there will be no change in the arterial pressure due to isoproterenol administration, because the receptors are blocked with the beta blocker. So this is the action of the beta blockers. So, and the epinephrine has this kind of action that increases the blood pressure, then decreases the blood pressure. And the increase in the blood pressure is activated by the alpha-1 receptors that are located in the arterial vessels, and veins, and arteria and veins. So, and that is why when we pre-treat with the alpha blocker, this alpha activation is blocked, and we only see beta. So, and beta is the action on the beta 2 receptors of the vessels that give blood to the to the skeletal muscles. So we only see beta 2 component of the epinephrine, and vice versa. If we treat with a beta blocker, then we only see alpha component, and there is no relaxation of the smooth muscles of the vessels. That is why there is no decrease in the blood pressure. And then the norepinephrine has mostly activates the alpha receptors. There is almost no beta component, and that is why we administer the alpha blocker, then there will be decrease in the activation of alpha receptors, but because norepinephrine is so so well activates the alpha receptors so much, So the alpha blockers cannot completely block and antagonize the action of the norepinephrine. That is why we still see a little increase, and the beta blockers will not affect much that, and I think they don't affect at all. So norepinephrine action is not antagonized by beta blockers because we don't see the beta action here. There is so little beta action of the norepinephrine, so that is why almost no difference with the beta blockers. So, and notice that the epinephrine action is reversed with the alpha blockers. So if epinephrine is here, then its action will be vice versa, because here there is also beta action, but it is not seen because of the alpha action, because these cues are together. So the actions, so when we summarize the positive and negative numbers, they like a large positive number with a small negative number. We don't see the small negative, we only see the summary is the one large positive. So, and that is why there is no beta component here. We only see it here at the end a little bit, but when we block the alpha, then we see the beta component of the epinephrine. That is why this is a reverse of the action of the epinephrine while administered at during the with the alpha blocker pre-treatment. So this is the this was the pre-treatments with the alpha and beta blockers for the beta agonist and non-selective alpha beta agonists commonly used. And adverse effects include orthostatic hypotension, and orthostatic hypertension means the decrease in blood pressure when changing the position of the body from the sitting to the standing, or from the lying to the sitting, or from the lying to the standing, and this change usually requires to be fast. So when you wake up fast at the morning, when you are late for the classes, for example, sometimes you may notice uh, the vertigo and lightheadedness. Have you ever feel that?
Yes.
So this is due to the orthostatic hypotension. So it is seen commonly even without the treatment with the beta blockers or alpha blockers. So when your vessels, like when you wake up at the morning, so normally it is not very prominent, because when you change your position of the when you change your body position, uh, the your ear will feel this change because of the snail snap that is in your ear. So there is special um, detector in your ear that will feel the change of the body position, and then it sends signal to the central nervous system, and central nervous system sends signal to the vessels of the extremities, the legs mostly, and also the hands, and then vessels in your hands and the legs are contracted, so mostly veins that have a large capacity, they're contracted, and that prevents the movement of the blood to the legs. So the blood remains in your brain, and that helps you to prevent this adverse effect. So uh, if if you stand up too fast, you can even in some ladies that are very sensitive and very light, very small, very tiny, then that can result in syncope. So they can lose their consciousness and fall. So like when have you ever seen when in like in theater or the films, in the movies, the ladies are shocked with some event, and they ah, and they fall.
Yes.
Yes, so this is like,
Yes.
have you ever felt that yourself?
I no, I saw it in movies only.
Movie. So it's
Yes.
very common. Like actresses, they make it very well. So and then men around uh, try to capture the lady, and then uh, start to treat her. So this uh, this is very common, mostly in female, but can be also seen in men, especially in older men. So uh, and the reasons are actually different because, for example, this can be due to the low volume of the blood, because the female lose the blood during the menses, and also females have less blood in the body than men, and that actually predispose the females for this adverse effect. Uh, and that is why when you stand up at the morning, don't be in a rush. So first stand, sit, then wait a little, and then slowly stand to prevent this lightheadedness. And then also make a physical exercise at the morning. So at the morning you can stimulate your heart rate, so and that increases the blood pressure, so to prevent the syncopes.
Is it okay if this happens during the day, not just in the morning?
Yes, it is okay. It can happen anytime if you stand up very fast, uh, unless it's um, lead to the loss of the consciousness. You should not worry much. So it's normal, and if you want to prevent that to happen, then try to stimulate to exercise your vessels. So make some running during the evenings, so that increases the blood flow and also stimulates the muscles of the vessels, or do any other physical exercise regularly, that will decrease the incidence of the syncopes. But if you are okay with that, just uh, uh, no need to do anything. So just be aware that you need to stand up slowly. So
Okay.
uh, the most dangerous is are injuries because of the fall. So if you don't fall, then that's fine. The only danger is that the patient can fall after, and when during falling, he or she can receive a trauma of the head, trauma of the uh, like the vessels, like if there is some sharp object on the way of the falling, and then that can uh, so and there is no one around, then a person can obtain this trauma and then can die because of the trauma. Like if someone working at the in construction buildings, so then that is dangerous. But one that is at home or at university or like in the safe places where there are no sharp objects to fall on them and die, or like there is no the height that from falling from that height you can die, then that is normally or all is fine. So but so there are some restrictions on the type of the job you have, so no, or it's not recommended to work in the uh, dangerous conditions. So, and usually that can be easily treated uh, by like yeah, depending on the reasons, it can be easily treated too. Uh, Usually the blood volume is low, so it's recommended to increase the blood volume by uh, by fluids, and also so the reason is like because the reason why it's happening at the mornings most is because we don't have much fluids during the volume, the blood volume decreases because uh, we don't eat and we don't drink during the night. So, and usually we all sleep by lying on the bed, and then we raise up fast. So but during the normal day we usually don't lie, and that is why there is no this effect. So this is orthostatic hypotension. So uh, orthostatic hypertension is very common and universal for all antihypertensive medicines. Some medicines have higher, others have low. Like alpha blockers have higher, beta have lower. And then second is tachycardia. Tachycardia is seen mostly reflective because beta blockers will not stimulate the beta 1 receptors, but they will decrease the uh, blood pressure, and decrease in the blood pressure is noticed by the body, and the central nervous system will obtain the pressure uh, of the blood from the special receptors in the sinoatrial vessel, from the place where the artery is going out from the heart. And there are receptors in the carotid sinus that are very uh, susceptible to the change in the blood pressure, like uh, when you have a pressure sensor in your tire, then if you have a puncture in one of your tires, then the the pressure sensor will notify you about the change in the decrease of the pressure in your tire, so you don't get to the accident. So the same way the uh, the uh, pressure sensor in the vessel in the human body reports the decrease in the blood pressure, that is because of the administration of the antihypertensive agents like alpha blockers or beta blockers. But the body is not aware that you are decreasing the pressure yourself because of the high pressure. So, and that is why they report this change, and then the central nervous system will increase the heart rate to compensate. So, and this is called reflective tachycardia, and is the second common adverse effect. So that slightly increases the pressure first, but then the pressure decreases because it's not very effective. But still tachycardia can remain, so, and you can feel, patients usually can feel the tachycardia because it's like they can feel their heart is pulping fast. And then dizziness and headache. So dizziness is not because of the orthostatic hypotension. There may be dizziness all the time. So not only when you stand up fast, but because of the decrease in the blood pressure, the central nervous system, so the brain is uh, lacking oxygen because there is less pressure in the blood system, and the brain will get less blood because of that, because the brain is at the uh, top, so, and it's higher than the heart, so, and that is why uh, when the pressure decreases, then that decreases much the amount of the oxygen delivered to the brain, and brain is very susceptible to that, and that is why it may result in headaches and dizziness. Headaches can be easily treated with painkillers like the acetaminophen usually is used, and usually headache is common at the start of the treatment, but after several days or weeks it will subside. So first several weeks usually all the patients require the treatment with the painkiller to prevent the headache. And then dizziness, there is no treatment, but usually is not much trouble. So just make sure that you don't fall. And the last but not the least is the sexual dysfunction, seen both in men and women. So in men, the erectile dysfunction is reported both when using alpha blockers and beta blockers too, despite all the actions of the erectile function is mediated by the alpha receptors. For some reason, beta receptor blockers decrease the man libido too, and then the female libido is also decreased. So that is why most couples report the sexual dysfunction and decrease in the uh, sexual the decrease in the sexual activity. So this is not usually not much problem for the older couples, for older men and women, because they are treated with the antihypertensive medicines of more frequently, but for the young couples, this is usually in one of the reasons to discontinue the medicine. So, and this is not good because discontinuing antihypertensive medicine results in hypertension and then potentially the heart diseases and vessel diseases. So, uh, so patients that taking medicines, the antihypertensive medicines mostly, should be aware of this for adverse effects because they will probably feel all of them. So, and uh, you should uh, tell the patients before dispensing the drug about all these adverse effects, so they will be prepared. And then also you can recommend a, painkiller against the headache, so you can recommend acetaminophen or aspirin for the headache, and then you can also recommend sildenafil or Viagra for the sexual dysfunction in men. For the female, there is nothing to recommend yet. So you will probably tell uh, the the men counterpart, so to men, to make some extra treatment for their spouses. So then Propranolol is a prototype drug among the beta blockers, and the action of the propranolol uh, is uh, is diverse because it will block the beta receptors and beta 2 receptors and beta 1 receptors, and the beta 2 receptor block will lead to the bronchoconstriction. That is no problem in the healthy patients, but in patients with the asthma, that will predispose the asthma attack. That is why propranolol is contraindicated in patients with the asthma. And other beta selective blockers, beta 1 selective blockers, can also lead to, in high concentrations, can lead to the bronchoconstriction, but in much less. And that is why can be used in the asthmatic patients. However, the caution should be taken because they still can predispose the asthma attack. So then the vasoconstriction of the peripheral vessels uh, that go to the skeletal muscles. So this is also a constriction that slightly increases the resistance of the vessels, but will not increase the blood pressure, because these vessels are very small and will not contribute much to the overall blood pressure. Then the increase of the sodium retention because of the decrease in the because of the increase in the reabsorption of the sodium uh, in the nephrons. And finally, and most importantly, there's a decrease in the cardiac output that decreases the blood pressure. So it decreases the rate of the contractions and the force of the contractions of the heart, and this is the desired effect. So that is also other beta blockers, selective beta blockers like metoprolol, atenolol, acebutolol, and nebivolol will also make this action, but they will not make this. So bronchoconstriction and reflex peripheral vasoconstriction are not seen with these selective beta blockers. That is why they are referred, and metoprolol is mostly used as a beta blocker. And then for the these adverse effects that we discussed first were for the alpha blockers. So for the prazosine, trazosine, dexazosine, and phenoxybenzamine. Uh, and these are the adverse effects for the beta blockers. So adverse effects are very like the same. There is also orthostatic hypertension, but additionally there is a fatigue. Fatigue is because of the decrease in the heart rate, and then bronchoconstriction is mostly seen with the propranolol. Sexual dysfunction also seen, so like same as the alpha blockers, and then arrhythmias when the drug is discontinued. So if we discontinue is not is that discontinue is abrupt without decreasing the dose slowly. So beta blockers, when the physician wants to discontinue beta blocker, he or she will decrease the dose slowly, like not like fast like this, but slowly over 1 month. So decreasing the dose every week to a small amount, like 1 week we decrease to the 100, like we take the 40 milligram of the propranolol, then next week we take the 30 milligram, then at 2 weeks after we take 20 milligram, and then 3 weeks after we take 10 milligram, and then we can only then we can discontinue the drug completely over, so decreasing the dose over the 1 month, and that will prevent arrhythmias that can be very dangerous because that can lead to the death. So that is why don't discontinue the beta blockers abruptly, or and also make sure that the patient have that take the medicines regularly. They have the stock of the beta blocker, like metoprolol is commonly used. So, and that is why you can make sure that your pharmacy have enough beta blockers so that patients can get it, so they don't discontinue abruptly. So and there are also a partial agonists like pindalol and acebutolol, and the partial agonists, so these are agonists and antagonists, we are familiar with that from the previous classes. And then the partially antagonists activate but unable to respond to more potent catecholamines. So the receptors actually cannot respond to more potent catecholamines because these agonists will not lead to the full effect. So they only make decreased cellular effect, but because they take place in the receptor, they don't block receptor, they activate receptor, but they activate it less than epinephrine, and that is why they are partial agonists. So if the patient is, so if receptors are activated by other uh, full agonists, and then we add the partial agonists will decrease the action like the blockers. So that is why they sometimes they named the agonist antagonists or partial antagonists. But here as actually it's named partial agonist, that is actually the same. Partial agonist, partial antagonist, or agonist antagonist are all the same. So, and these are the indications for the beta blockers. So it's hypertension, most common indication. Glaucoma is for the treatment of the eye disease, pressure in the eye. Timolol is used commonly because it's available with the eye drops. They will decrease the production of the eye aqueous humor in the eye, that will decrease the expression in the open angle glaucoma only. So in closed angle glaucoma, timolol and other beta blockers will not be effective. And then migraine, for the treatment of the migraine, the propranolol uh, is used to prophylaxis. So if the pain is not yet started, then propranolol can be used for prophylaxis. And then during the thyrotoxicosis, that is a rare disease, usually because of the cancer of the uh, and for thyroid, and propranolol reduces the increased heart rate and arrhythmia because of the thyroxine production that will increase the release of the epinephrine from the adrenal medulla. And then arrhythmias after myocardial infarction are also very dangerous. That is why the propranolol and metoprolol are used to decrease the secretion of the renin from the liver. So that is why the is used for prophylaxis. And other types of the arrhythmia include the supraventricular tachycardia, and because of the conduction increase, so they slow the atrioventricular conduction. And then the last but not the least is angina pectoris. So it's a specific heart disease that is actually, we will discuss this separately because it's very complex. So these are all the indications for the alpha and beta blockers. Then what are your questions?
No questions, I think.
As usual. So then if no questions, thank you for joining this lecture, and let's continue with the practice.